Good afternoon, everyone. Center of Excellence, PGIMER, welcomes all the participants for today's RDLS session. Today's topic is integration of NCD screening and management among PLHIV at ART centers. And the speaker is Dr. Naidu, sir. Dr. Naidu, sir, is the Deputy Program Director for COE PGIMER, Chandigarh. We welcome you, sir, for today's session and request you to start the session.
Thank you, and good afternoon, everyone. So today I'll be discussing about the integration of the NCD screening and how do we baseline management of this some of the specific NCDs among PLHIV that can be done at the various at our ART centers. So this will be the outline of the lecture today. So first we'll be speaking about the background of the HIV and the non-communicable disease, then various common NCDs like hypertension, diabetes, and cerebrovascular diseases. Then how do we screen and assessment, how do we do assessment of the basic NCD? Then how do we integrate this NCD care into the our day-to-day practice in the ART centers, and how to proceed further. So why is it important for us to screen all PLHIV for NCDs? Because as we know that with the use of effective ART therapy, the lifespan of these patients had improved significantly, and the disease has been, which was initially thought to be a life-threatening condition, now we refer to it as a manageable chronic condition. So, and also there are now significant number of patients who are coming to our centers who are more than 50 years of age. So as we all know, non-communicable diseases are more common as the age increases. So there is an increased prevalence of non-communicable diseases among PLHIV compared to the initial few years of the disease course. So PLHIV also face different health challenges due to aging, are more likely to develop NCDs, and also non-communicable. These NCDs are becoming one of the leading cause of morbidity and mortality in PLHIV patients. So the detection and timely management of various NCDs, which I'll be discussing in the subsequent slides, is very critical in holistic management of PLHIV. So this is a list of various non-communicable diseases that we come across. This is not specific for PLHIV per se, but this is what we usually see in general population as well. So the commonest are the cardiovascular and respiratory and endocrine diseases. Among the cardiovascular is the hypertension or the ischemic heart diseases, what we call as the heart attacks. Then the strokes, either ischemic or hemorrhagic strokes, and rheumatic heart diseases we might sometimes see, even though their prevalence is coming down in the recent times. Then among the respiratory conditions, asthma and COPD or occupational lung disease is pretty common even in general population, and also can be seen in PLHIV as well. Then among the endocrine conditions, diabetes, as we know, in India is one of the countries where there is highest prevalence of diabetes among general population. So even PLHIV patients can develop diabetes and might complicate the disease course. The other NCDs include the chronic kidney diseases, then psychiatric diseases like depression, anxiety, and schizophrenia. Various cancers, which can be breast cancer or cervical cancer or lung cancer, then prostate or colon or stomach, and the presence of various musculoskeletal disorders like arthritis, which can develop in any patient of PLHIV. So we'll not be discussing about all these individual diseases. We'll only be discussing about 3 or 4 conditions which are more common and which are easy to screen in our ART centers. So coming to the Indian scenario in general, this is a large study done in collaboration with ICMR and was published somewhere around 2010. Where more than 1 lakh general population were screened for various non-communicable diseases. So as per this study, as we can see, the overall prevalence of diabetes is somewhere around 11% in India, and the prevalence of pre-diabetes is around 15%. So overall, there is almost 1/3 of the patients in the general population are at risk of developing diabetes or are already diagnosed with diabetes. And the prevalence of hypertension is also similar, nearly 1/3, like almost 1 in 3 patients will have hypertension in the general population. The prevalence of generalized obesity is about 28%, and abdominal obesity is almost 1 in every 2, almost 40%. And dyslipidemia is one of the most common risk factor found in the study, seen in about 80% of the patients. And all these metabolic NCDs, except for prediabetes, were more prevalent in the urban population than the rural population. So what does this percentage mean to us? This percentage, if we can translate into our into the absolute number of people who are getting affected, you can see that the numbers go into millions, like more than 100 million to 200 to 300 million of individuals who are getting affected with these non-communicable diseases. So, and the most common non-communicable disease is the cardiovascular disease. And as you can see in this diagram, it is the #1 cause of cardiovascular cardiovascular disease is the #1 leading cause of death worldwide. Also, 1 out of 3 deaths worldwide are due to cardiovascular diseases. And it is more important for us because 3 out of the 4 deaths due to cardiovascular disease are occurring in low to middle income countries, which India is also a part. So this figure of 3 out of 4 is very important with respect to our local demographics. The important cardiovascular diseases that we commonly see are the coronary heart disease, the cerebrovascular disease, and the peripheral arterial disease, meaning development of ischemia in the limbs, either lower limbs or the upper limbs. Then rheumatic heart disease, as I've already told, the prevalence is coming down, but occasionally we do come across some patients with rheumatic heart disease. Then the prevalence of thrombosis, either in the lower limb veins, deep venous thrombosis, or the pulmonary embolism. So why is it that Indian patients are at increased risk of developing this cardiovascular disease? So there are some theories which can explain this increased risk in India. One is that there is an increased biological risk, either because of the genetic or racial difference predisposition of the of Indians, and also early life influences of Indians can also increase the biological risk of developing a cardiovascular disease. And also there is a change in the population characteristics. There are changes in the socio-economic and the socio-demographic pattern of individuals in India over the period of time. And also there is environmental changes happening with increasing air pollution and other environmental mediated triggers for developing cardiovascular disease. And also socio-cultural changes have occurred. There is increased number of patients who are not practicing healthy lifestyles like regular exercise, or who are having a bad dietary habits like consuming high salt and high fat diet. And also there is a change in the economic milieu of the general population, which is also contributing to the increased risk of cardiovascular disease. So what are the various risk factors for cardiovascular disease? As you can see, hypertension, diabetes are the most common. These are the most common risk. These are prevalent in about 1/3 of the general population. These are the highest risk factors, which are highest contributing highest to the development of cardiovascular disease. Apart from that, there would be dyslipidemia and obesity are another 2 important risk factors which contribute significantly to the development of cardiovascular disease. And I'll be discussing about the cutoffs for obesity for the Indian population, and also the cutoffs for waist circumference at the later slides. Other risk factors include physical inactivity, tobacco use in any form, not only smoking, but also chewing of tobacco can also increase the risk of cardiovascular disease. Then excessive alcohol consumption, and also practicing or consuming an unhealthy diet and nutrition. And relatively unmodifiable risk would be a family history of cardiovascular disease. So For detecting various non-communicable diseases, there is a concept called opportunistic screening. So what do we mean by opportunistic screening is we try to screen for various non-communicable diseases in patients who are presenting to us for any reason. Meaning to say that whenever there is an opportunity to assess a patient in the healthcare facility, we do basic screening for presence of various non-communicable diseases. So with respect to the ART centers, our opportunity is when the patient is presenting to an ART center either for the first time or during subsequent visits. That is an opportunity for us to screen individual patient to whether the patient is having any risk factors or presence of various non-communicable diseases. So what is the advantage of doing this opportunity screening? There is a chance that we detect this disease very early, and which also results in initiating management at an earlier stages, which the management could be either lifestyle changes or pharmacological therapy. And both of these interventions would lead to improvement of health and well-being of the patient, and also prevent various comorbidities that might occur because of the presence of this non-communicable disease. Like as I've already said, hypertension and diabetes are risk factors for ischemic heart disease or stroke. So if we can detect these hypertension, diabetes in earlier stage and start pharmacological therapy, we might prevent the development of various end organ damages like ischemic heart disease or chronic kidney disease or retinopathy. So what does the national technical guidelines say regarding the screening for NCDs? The overall aim is for early detection of NCDs among PLHIV. This helps in reducing morbidity and mortality associated with the various NCDs among PLHIV. And this can be done by providing integrated and comprehensive management of HIV and NCD in a routine program setting. So what should we do when a patient presents to an ART center? So the assessment for the various risk factors for NCD should be done at the time of the first registration at the ART center, and subsequently to be repeated every 6 months. So this assessment will include both history taking and examination, and if required, investigation. So in the history, we should always inquire about past history of heart disease, strokes, diabetes, or hypertension, any symptom related to the end organ damage, like symptoms related to the involvement of heart, symptoms related to the involvement of kidneys, symptoms related to the involvement of lungs, or symptoms related to the involvement of peripheral nerves should be inquired with all the patients whenever they are presenting for the first time and 6 months thereafter. And sometimes patient might not give us symptoms, but if we can elicit the history of whether the patient is taking any medication to any of this non-communicable diseases, like patient is already on antihypertensive drugs or patient is already receiving diabetes treatment. So these can also be inquired. And the other important thing that we need to find out is whether the patient is having any history of usage of tobacco, either currently or in the past, because even if the patient has consumed in the past and currently not consuming, still there is a relatively increased risk of developing various cardiovascular diseases, and also about alcohol consumption and other illicit drug usage. Then we should also inquire about the lifestyles and whether there is any family history of any premature heart disease or strokes. And as far as the clinical assessment is concerned, all patients should have a baseline BMI and waist circumference. Blood pressure should be measured at baseline and after 6 months. Then signs and symptoms of diabetes should be looked for. Then examine for signs of various end organ damages like pitting edema, presence of heart murmurs or basal crepitations in the lungs, and lipid profile should be obtained at the base. So this slide again summarizes the same point, trying to highlight that ART center, any patient who is present in ART center should undergo screening for diabetes, hypertension, cardiovascular disease, and various common cancers. Uh, and then screening shall involve simple history, as I highlighted in the previous slide, and also general physical examination, the basic general physical examination to identify most of the non-communicable diseases. And routine screening and management of mental health disorders should be provided to PLHIV. I'll be speaking in more detail about the mental health disorders in subsequent slides. But this is one area which is often being neglected both by the patients and by the healthcare professionals. So we need to be relatively more vigilant in detecting mental health disorders in these patients. So next, coming to the, we'll be discussing about 3 or 4 common non-communicable diseases. How do we screen and how do we do the basic initial management at ART centers? So first, coming to hypertension. So who all should be screened for hypertension? Any patient, any PLHIV who is above 18 years of age should undergo a screening at the first presentation by measurement of blood pressure. So blood pressure measurement is a very simple assessment, and it has to be done at the time of registration in the ART care and subsequently every 6 months, or even earlier if there is a need. Like if the patient says there is some symptoms which are related to hypertension, we can do a screening at that point. Or if you feel that there is some need for measuring blood pressure, we should always perform a blood pressure measurement of these patients. So this picture is actually beautifully depicting how a blood pressure has to be measured in our clinic. So as you can see, the patient has to be seated, supported well. Both the arm and the back should be supported, and the feet should be placed firmly on the ground. The patient should not cross the legs while sitting, and then the patient should be resting for at least 5 minutes before we take the measurement. And also the patient should not be talking while we are taking a measurement. And regarding the positioning of the cuff has to be at the level of heart, and also a proper size cuff should be placed, because inappropriate size cuff would lead to either increase or decrease in the measurement of the blood pressure. So why is that all of these things are essential in measuring BP? Because as you can see in the left-hand side, this table, unsupported back or feet can increase the blood pressure recording by up to 6 millimeters mercury, and unsupported arm can have a increased recording of up to 10 millimeters of mercury. So, for example, if there is a patient whose recording is showing that the systolic blood pressure is say 144, so and that if the 10 millimeters is being contributed because the patient is not properly seated, then actual recording would have been somewhere around 134 or 136. So with this value of 144, we will label this patient as hypertensive, but in fact, this patient is actually not having an hypertension if we go by the definition. So that is why it is important that the proper position of the patient should be there, and also in relation to the inappropriate cuff size, as you can see here, up from 2 to 10 millimeters of mercury difference can be seen compared to the actual BP recording if there is an inappropriate cuff size, or if the patient is covered in a lot of clothing, and on top of that, if we are measuring the BP. This becomes even more important with the present season, because most of the times patients do come with covering of 2 or 3 different sweater layers. So it is essential that we try to wrap this cuff around the directly over the skin, or a very thin layer of body. The other important thing is the patient should not be talking while we are measuring the blood pressure. Also, the patient should have emptied the bladder before we measure the blood pressure, because both of these things can have a sympathetic drive, and there is an increase of blood pressure while we are recording. So, what is the definition of hypertension? As per the various guidelines, the definition of hypertension is when there is a BP recording systolic of more than 140 millimeters of mercury, or diastolic more than 90 millimeters of mercury. And this recording should be present on at least 2 different occasions, measured at least 1 to 4 weeks apart. So with the single recording of blood pressure which is more than 140 or more than 90 millimeters of diastolic, we cannot label the patient as having hypertension. We should have at least 2 different recordings. However, if the patient is coming with in a situation of hypertensive urgency or emergency, then even a single recording is also important. So what do we mean by hypertensive urgency? It is when the BP recording is more than 180 millimeters of systolic or more than 110 millimeters of diastolic, uh, 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 with no evidence of end organ damage. So if there is an evidence of end organ damage with such high BP, then we label it as hypertensive emergency. Both of these conditions are medical emergencies and should be treated immediately with appropriate drugs. So even if it is the first reading that the BP is more than 180 by 110 millimeters of mercury, we can still initiate therapy in these patients. So what are the additional investigations that we need to do once we make a diagnosis of hypertension in the patient? The additional investigations include the assessment of fasting blood sugar, because as we commonly see, most of the patients who are hypertensive will be having an underlying diabetes as well, and vice versa is also true. So the patients who are having diabetes are also at increased risk of developing hypertension. So always, any patient who is newly detected to have hypertension, we should always assess for the underlying diabetes status. And then we have to get an urine analysis to see for any end organ damage in the kidney, the form of presence of proteinuria or RBCs. Then also we should get a renal function test with the serum creatinine and potassium to assess for the underlying renal functions. Then lipid profile has to be done whenever we make a diagnosis of hypertension. Also, we should get a baseline ECG screen to see if there is any subclinical cardiac involvement. So once we screen these patients and do the initial assessment, then we have to start therapy. Then what is the target for our therapy? So the target for our therapy is that any patient who is less than 80 years of age, the blood pressure should be less than 140 millimeters of mercury systolic or less than 90 millimeters of mercury diastolic. For patients who are older than 80 years, then the cutoffs are slightly higher. That is less than 150 millimeters of systolic is enough. However, the diastolic is the same even if it is more than 80 years of age. So, and all patients who require these all patients will also require lifelong lifestyle modifications, and this can be in the form of dietary modification. The most important is that salt restriction should be advised to all of these patients. Salt restriction means salt consumption should not be more than 5 grams per day. And we should encourage them to take low-fat diet and have a regular exercise. And also encourage them to maintain their weight and with a target BMI of between 18.5 to 22. And especially among those patients who are smokers or tobacco consumers, we should encourage them for coming to the pharmacological treatment of hypertension. There are various drugs which we can use. Commonly used drugs are the calcium channel blockers or the angiotensin receptor blockers. Other groups include ACE inhibitors and various diuretics. Most commonly used are the thiazide diuretics and beta blockers. So once we, how do we manage these patients? Hypertension can be divided into various grades, grade 1, grade 2, grade 3, depending on the value of the blood pressure. Grade 1, usually we say that initially we should start them on lifestyle modification for at least 3 months. However, if they are not responding to lifestyle modification, we can start them on pharmacotherapy. The usual advice would be to start with one drug, gradually titrate it depending on the blood pressure value to the maximum tolerated dose. And on top of that, if the patient is still uncontrolled, then we can add on a second drug. But in patients who are presenting with grade 3 hypertension, straight away we can start with 2 drugs, and preferably one of those drugs should be a diuretic. And along with this, lifestyle modification should be advised to all of the patients. So the final thing in the management of the hypertension would be, when should we refer these patients if we are not able to manage hypertension at ART center? So it is being told that all medical officers at the ART center can initiate treatment if the patient is having uncomplicated hypertension. However, if the patient is having grade 3 hypertension or if the patient is requiring multiple antihypertensives or if the patient is developing an end organ damage because of hypertension, then it is always better to refer to a center where there is uh, uh, various specialists to manage various complications that are arising from hypertension. So various district hospitals and other centers have a NCD clinic. So we can refer these patients to the NCD clinics. Or if the patient is present in a government college or an institution, then we can refer them to the appropriate departments for the management of this end organ damage. So the next important disease that we are going to discuss is the diabetes mellitus. As I've already told, this is also equally prevalent as hypertension, nearly seen in 1/3 of the general population. So even in PLHIV also there is an increased risk of uh, uh, not an increased risk, but they can also have the similar prevalence of as compared to the general population. So when should we screen these patients? All PLHIV should undergo screening with at the time of registration to the ART center, then 1 to 2 months after initiating the ART therapy, and then subsequently every 6 months. And whenever we are changing a regimen or either by substitution or by switching a drug for various reasons, then again we should check for the glucose control. And as and when the examiner or the patient feels that there is a need for checking the diabetic status, we should also perform screening at that moment. And the screening can be performed by conducting a random blood sugar test. So whenever we are screening this patient, or like one is the symptoms, then the other is the blood sugar testing. So what are the symptoms that we need to remember, which can indicate that there is an underlying diabetes? So most commonly everybody would know is that the symptoms of diabetes would be polyuria, polydipsia, and weight loss. Apart from that, the patients can also present with unexplained tiredness or weakness, generalized pruritus, or patient can have recurrent infections, most commonly urogenital or sinusitis, or there might be delayed wound healing in these patients. So all of these patients we should screen for underlying diabetes status. And depending on the blood sugar value, the diagnostic criteria for diabetes are as shown below. So symptoms of diabetes plus any random blood sugar value of more than 200 milligrams per deciliter, we can say that the patient is having diabetes. If we are taking the fasting plasma glucose, then the cutoff is more than 126 milligram per deciliter. So the important thing we need to remember here is that it is a plasma glucose value. The cutoff is 126. But if we are using a capillary blood by glucometer, then the cutoff is much lower. It is somewhere around 110 milligrams per deciliter. So we need to be a little bit more careful while interpreting this value, because if plasma glucose estimation is done, then the cutoff is 126. And that is what has been included in the definitions by various associations. So that is what we need to practice. Then postprandial, that is 2 hours after meal intake, if the RBS is more than 200 milligrams per deciliter, then again it is indicative of diabetes. Or if the glycated hemoglobin, that is HbA1c, which is more than 6.5%. And if the patient who is having abnormality in any of these 4 measurements, this has to be reconfirmed with subsequently also to establish a diagnosis of diabetes. So random blood glucose is measured at any time of the day without any regard to the time or since the last meal, and it is very easy to perform. And any value which is more than 200 milligrams per deciliter is indicative of diabetes. But any patient who is having a value which is more than 140, we should be relatively more vigilant in screening for diabetes in these individuals. And here in this picture, it shows the various steps on how to measure glucose through a glucometer. So I think most of us have performed it at multiple occasions, or at least seen someone else performing at multiple occasions. So I'll not be going into details of the steps of this testing. This is again a repetition of the same thing. The cutoff values for fasting blood glucose is 126 milligrams per deciliter, and for postprandial it is more than 200 milligrams per deciliter. And HbA1c cutoff is 6.5%. So how do we monitor these patients who are diagnosed with diabetes? So fasting and postprandial blood sugar should be done at least once a month or more often if required, especially in those patients who are not achieving the target values of blood sugar, that is less than 126 fasting and less than 200 in the postprandial blood sugar. Then HbA1c at least 6 to 12 monthly if the patient is well controlled, or as early as 3 months if the patient is not having a good control. There is no additional advantage of measuring it every monthly because the changes in HbA1c would take some time to reflect. So the once every 3 months should be enough in those patients who are not well controlled. Clinical examination needs to be done during every visit, and if not possible in every visit, at least once every 3 months, the clinical examination in relation to the various signs and symptoms of diabetes should be performed. And all patients who are diagnosed with diabetes should be assessed for the presence of retinopathy by detailed ophthalmological examination, then nephropathy by urine routine analysis and creatinine estimation, then neuropathy by either clinical symptoms or, if required, a nerve conduction study. Then presence of peripheral vascular disease and coronary artery disease. And this screening has to be done at least once every 6 months and earlier if needed. We should also encourage all these patients to optimize their weight and maintain the weight between the with an BMI target of between 18.5 to 23. And also we should ask them to control their blood pressure and dyslipidemia to prevent various complications. Then routine examination of food. This is again very important because most of these patients with uncontrolled diabetes can develop diabetic foot, resulting in ulceration and secondary infection. So routine examination of foot is to be done during every visit, and education regarding good foot care should be given to patients at each visit. And as I already said, in hypertension, we should encourage the patients for tobacco cessation and also moderating the amount of alcohol intake. So the additional investigations again would be to get the lipid profile, then serum creatinine and urine analysis to see for proteinuria as a marker of end organ damage. And also, as I've already told in hypertension, in any patient who is having diabetes, we should also screen for underlying hypertension. So again, coming back to the referrals, when should we refer these patients? Screening, diagnosis, and management through lifestyle modification can be done at the ART center. However, to initiate oral hypoglycemic agent, the patient has to be referred to a physician who is expert enough to deal with diabetic patient. Then continuation of treatment can be provided by the trained medical officer in patients, especially who are having controlled diabetes. And management and follow-up by physician are recommended in patients who are having uncontrolled hyperglycemia despite maximum doses of metformin or sulfonylurea, or in patients who are having complications like foot ulcers, retinopathy, neuropathy, or nephropathy. So next, the third condition that we are going to discuss is obesity. So obesity is defined by the measurement of body mass index. So body mass index is very easy to calculate. As you can see, the formula is shown here. It is calculated by weight in kg divided by height in meter square. So it is very easy to perform. We can simply weight and height are easily calculated at our ART center. So it is very easy to calculate BMI on our computer, on our mobile phones, or sometimes you can use the apps also to calculate the BMI. So based on the BMI value, the patient can be categorized into various groups. Basically, BMI indicates both the underweight category and also the overweight category. So underweight is when the BMI is less than 18.5 kg per meter square. And normal ideal is between 18.5 to 22.9 kg per meter square. 23 to 25 is labeled as overweight, and anything above 25 is obese. So these cutoffs would be different for different countries. So these are the cutoffs which are being given for Indian population by the ICMR. So this is what we usually follow. Because if we look at the Western cutoffs and the cutoffs given by WHO, the cutoff for the obese category would be much higher. I think it is somewhere around 28 kg per meter square. And also central obesity, as far as the Indian patients are concerned, any waist circumference which is more than 90 centimeters in males or 80 centimeters or more in females would be taken as central obesity. And the last group of NCD that we are going to discuss is the mental health issues. So as I've already told, this is one of the most common comorbidity that we come across in PLHIV. However, this is one of the least recognized and least least managed comorbidity in PLHIV. So why is it important that we should screen all patients with PLHIV for the mental health disorder? Is because there are studies which have shown that various mental health disorders like depression, especially depression, was seen to be 2 to 3 times more prevalent in PLHIV compared to the general population. So there are various reasons why there is an increased prevalence of depression and PLHIV, because one reason is that HIV per se might be contributing, infection per se might be contributing to various psychiatric manifestations. And also there is various opinions and experiences regarding HIV from their surroundings, like from their family or family members or various neighborhood people living in the neighborhood, and also result in stigmatization of these patients and might result in development of various psychological issues in these patients. And it is also important to address this issue because it might presence of any psychiatric illness might significantly hamper the adherence of these patients to both ART therapy and also to the various other drugs that we are going to give, especially if they are having multiple comorbidities. And also eventually this will affect the mental well-being of the patient. So how do we screen for depression in PLHIV? There are two very simple questions that we can ask these patients. So it hardly takes 5 to 10 seconds to ask these questions. So these questions are actually not specific for PLHIV. This can be applicable to any person in general population as well. So the two questions that we need to ask every patient who is presenting to ART center are: during the last 2 weeks, have you often been bothered by feeling down or feeling depressed or feeling hopeless? And the second question is, during the past 2 weeks, have you often been bothered by little interest or pleasure in doing various things? So if the patient says yes to any of these two questions, then we should be doing a thorough screening for the presence of depression. So just by saying yes to one of these questions doesn't mean that the patient is depressed. We need to systematically evaluate this patient for the presence of depression by using various other questionnaires. There are a lot of questionnaires which are available to screen for depression or either screen or to assess the severity of depression, but the most common and easiest to perform would be the PHQ questionnaire. So this is the PHQ screening tool for depression. As you can see, there are 9 different questions related to the various day-to-day activities and how the patient perceives difficulty in doing these activities. And it is being graded from 0 to 3 for each question separately. And the cumulative score will be calculated by adding a score of individual question and a cumulative score can be obtained. So based on the cumulative score that we get, the patient can be labeled as having a depression or not having depression. So cumulative score of 0 to 4, then depression is very unlikely. However, we need to be vigilant and screen them in subsequent visits as well. The score is between 5 to 9, then it indicates that there is a mild depression. So what is our role if the patient is having mild depression? At the ART center, we can provide supportive counseling and continue to monitor these patients. And if the patient is receiving efavirenz as a part of his ART regimen, then we need to substitute this drug to prevent further worsening of the psychiatric illness. And any score which is more than 9 would be taken as moderate to severe depression. So if a patient who is having diagnosed to have moderate to severe depression, then obviously we'll provide counseling through trained counselor and we'll change the efavirenz to the appropriate drug. However, we should always refer these patients to a psychiatrist for further management and assessment and initiation of anti-depression medication. So, in the counseling, what can we do at the ART center? So we can give them psychosocial support. We can help them in developing skills which are helpful in self-management of the various depressive symptoms, and also various things that we can advise them to reduce the various stressors in the life. So for the psychosocial support, we can explain about the depression and assure that it can be managed. This is most important. The patient should understand that presence of psychiatric symptoms like depression or anxiety can be managed with appropriate treatment. Then feeling of hopelessness, worthlessness, negative emotions are part of depression and will revert with proper counseling and treatment. So these two are very important when we are counseling the patient. We should stress these symptoms which are arising because of depression can be reversed. There is a appropriate management is initiated. And also we should identify the supportive family members and also involve them in the day-to-day management of depressive symptoms. Then as regarding the self-management skills, we should ask them to identify activities that are used to that he or she are used to find interesting and pleasurable previously, and encourage to participate in these activities at regular intervals. Also, adequate and good quality sleep of at least 7 to 8 hours is very essential. Then encourage them to do various physical activities as per their convenience. And also we should inform that if there is any thought of self-harm, they should immediately contact the family members or the healthcare providers at the ART center. And we should also encourage them to identify and discuss various problem-solving techniques with them, and also suggest stress management activities like meditation or relaxation techniques in order to reduce the various stressors. So regarding the medical management of depression, both non-pharmacological and pharmacological interventions can be given. So for initiating pharmacological therapy, we should always refer these patients to a psychiatrist. And usually antidepressants, if it is a single episode of depression, usually I'll be given for 6 to 9 months. However, that decision of how long to continue would be taken by a psychiatrist. And the doses have to be started at a lower dose and gradually increased. The most important thing is that antidepressants should never be stopped abruptly, and they should be gradually tapered in consultation with a psychiatrist. As far as the drugs are concerned, there are two main classes of antidepressants, that is tricyclic antidepressants and the SSRIs. And the other challenge of detecting mental health disorders would be in children and adolescents who are living with HIV. So, because this particular age group, the children or adolescents, they might not come up with the direct symptoms like low mood, hopelessness, and other things which the adults might express. So we need to be very vigilant in detecting various clinical clues which might indicate that there is an underlying depression. So I'll be showing the various clinical red flags which highlight that the child or adolescent who's living with HIV might suffer from depression in the subsequent slide. Various studies have shown that the prevalence of mental health in this particular age group is somewhere between 6 to 12%. So these are the various warning signs or the red flags which we need to be aware. Persistent sadness, withdrawing from or avoiding social interactions, hurting oneself or talking about hurting oneself, talking about death or suicide, outbursts or extreme irritability which are unexplained, out of control behavior that can be harmful to either the individual or any of the surrounding persons, drastic changes in mood, behavior, or personality, changes in eating habits, loss of weight, difficulty in sleeping, frequent headaches or stomach aches, like various somatic symptoms, body aches, stomach aches, and headaches, difficulty concentrating either at the school or at home, changes in academic performance, and avoiding or missing school. If any of these 14 manifestations is noted in this age group patient, then we should be screening them for the presence of underlying depression. So, what should we do when should we refer these patients with any of the NCDs to various centers? So, for ART centers in the district hospitals, PLHIV with any of the NCD should be referred to the NCD clinic. There are various non-communicable disease clinics established at the level of district hospitals. So we can use we can take help from these NCD clinics in the management. And also, if the ART centers are at the medical college level or in institute level, then we can refer them to the appropriate specialty department. And for the mental health disorders, again, at the district hospitals, there is a national mental health program going on. So clinics are being established at district hospitals to deal with the mental health issues. So patients can be referred to those district hospitals. And at the level of medical colleges and institutes, we can take help of the psychiatrist or appropriate specialty department for management of the the next step is the important step is the recording and reporting of these screening results of this screening and screening methods and the appropriate management that we have initiated. In the section 13 and section 9 of white cards, we should always enter the details regarding the screening procedures that we have performed and also the initial management that we have initiated. And these details should also be captured in the IMS. Sorry. So in this diagram, we have already discussed about the screening for early detection and also when we should do referral to the for the diagnosis or management of various NCDs. So the third important component is the health promotion. So in the next subsequent slides, we'll be discussing about the various health behaviors. So behaviors which will result in better health of the patients. So physical activity is one thing. Active physical activity, the recommended is at least 150 minutes per week of activity should be there. That can be in the form of either walking, jogging, or playing any sport which the patient is interested in, or the practice of yoga or meditation. Then the next health behavior that we want is the weight control. Weight control as per the BMI. As I've already told, the ideal BMI is between 18.5 to 22.9. So we should encourage patients to maintain their BMI between these values. And also encourage them for a low calorie diet and dynamic physical activity so that they maintain their weight in the ideal category. Then as far as the diet is concerned, we should encourage them to take whole grains, vegetables, fresh fruits and vegetables and pulses, and restrict the salt intake to less than 5 grams per day, and also limit the use of various foods which are rich in sugar and high fat diets and deep fried items. And again, tobacco cessation, already highlighted in the previous two topics. So again, cessation has both tobacco cessation has both short-term and various long-term benefits. So we should always encourage the patients to quit smoking. And those patients who are not smokers, we should encourage them to continue in the same stream. And alcohol consumption in moderate amount has to be encouraged because excessive use of alcohol can lead to various problems. Then adherence to treatment should be encouraged. If the person is prescribed medication for any of one or more NCDs, then we should explain the dose and how many times in a day the patient has to take this medication. It is important because many times patient might be having not just one NCD, but a combination of 2 or 3 different NCDs. Patient might be having an underlying hypertension, diabetes with the coronary artery disease and dyslipidemia. So all of these medications need to be taken by the patient along with ART. So we should always explain the dose and how many times the patient needs to take, and also we should explain that any drug-drug interactions that might happen because of the ARVs and the various drugs that we use to control NCDs, and also explain the importance of adherence of these medications for proper management of NCDs, and also the proper control of the HIV infection. So next, coming to the role of various ART staff members. First, the role of nurse, staff nurse. So the role of staff nurse is to assist the medical officer or the SMO during the examination of patients and to assist them in follow-up care. And it is expected that the staff nurses perform the BP screening using BP apparatus, record the various anthropometric measurements like height, weight, hip circumference, and waist circumference of the patient during each visit. Height might not be required at each visit, but rest of the other things can be done at each visit. Record the results of the lab investigations in the survey form, and to explain the patient and family the risk factors for NCDs and promote healthy lifestyle. Then next, coming to the role of counselor, this is very important because this is an opportunity for us to explain or screen PLHIV patients for underlying mental health disorders by doing the basic screening as I've already shown. And any patient who has any doubt about presence of various mental health disorders, then using PHQ-9 screening has to be done by the doctor. Then also we should ask for personal and family history and risk behaviors, and the questions will assess the core symptoms of depression. And to provide counseling on the diet and lifestyle management, and also to provide counseling about the side effects of various drugs that the patient is taking. And coming to the role of medical officer, the role of medical officer is to take complete detailed history about various risk factors of the various NCDs, and also do thorough clinical examination to see for signs and symptoms of various NCDs. Then prescribe the appropriate laboratory investigations and confirmation of recording of the findings in the white sheet and white card of the patient. Then if BP or RDS is high, then the medical officer or the SMO is expected to start the preliminary treatment and make appropriate referrals if there is a need for specialist opinion. So again, management of NCDs at ART centers is a group, is a teamwork. The ART MO, SMO can start the treatment for the NCD at the ART itself. For the diabetes mellitus, we can start metformin or glimepiride. For hypertension, we can start amlodipine or telmisartan or ramipril. And if required, we can refer to the higher centers or the nearest NCD clinic for management, appropriate management. So there can be some challenges in managing these non-communicable diseases because some investigations might not be available at some of the ART centers which are located at remote sites. And they need to refer these patients to a different facility to get this basic screening workup done. So in that case, there is a chance that the patient might not reach this facility where we have referred to. So the proper assessment and timely assessment of the NCDs might not happen in these patients. Then the pattern of prescription of drugs varies from state to state, depending on the essential drug list that is available at that particular center. So sometimes we might not be able to initiate the appropriate preliminary management in these patients. And there might be complications arising due to either the underlying NCD or the treatment that we are going to initiate for the management of NCD. So we might need a specialist management managing these complications. To conclude, NCDs are being increasingly commonly recognized in PLHIV, and they are turning out to be a leading cause of morbidity and mortality among PLHIV, replacing the infectious causes as one of the leading cause of mortality. With aging population of PLHIV, NCDs are going to play a predominant role in the management of PLHIV in future. And screening for NCD is very simple. Basics like blood pressure measurement, random blood sugar measurement, assessment of BMI and getting the lipid profile done would help us in identifying most of the NCDs that we commonly see in the general population. Initial management of NCD is very much possible at the ART center and can be initiated by the concerned medical officer or NSMO. And integration of the NCD screening and management into HIV care is critical in achieving the holistic approach of management of PLHIV. So that is the end of the lecture. So if anyone has any questions or queries regarding the topics, I'm more than welcome to ask them.
Thank you so much, sir. Any questions from the participants? Please feel free to unmute your mic, or you can even type in the chat box. Any questions regarding NCDs? So I don't think there are any questions. Thank you so much for facilitating this session.
Okay, thank you so much.
Thank you so much, sir. Thank you to all the participants for patient listening. We'll conclude the session now.